Thank you, Dr. Ahmed. Excuse me. First of all, good afternoon. I'd like to thank really the organizing committee for inviting me to talk to you today about kind of review and an update regarding GI bleed, the upper and lower. Mainly, it'll be the upper, whether it's variceal or non-variceal, and then we'll touch upon the lower a little bit at the end. These are my disclosures. So really, I'll discuss the upper GI bleed resuscitation, risk stratification, medical therapy prior to endoscopy, endoscopic therapy, medical therapy after endoscopy, and then when do we restart our anti-thrombotic therapy regarding management, peri-endoscopic time, and then touch upon lower GI bleed and wind up with a conclusion. From a background standpoint introduction, the overall non-variceal upper GI bleed mortality is really 1.1 to 11%, depending on the study you look at, and has decreased over the past 10 years. Mortality is in principle related to the comorbid conditions, much less to the direct implication of the GI bleed itself. And the management is really based on endoscopic therapy as well as PPIs as an adjuvant therapy for that aspect. And the majority of the upper GI bleed comes from peptic ulcer disease. The incidence is high, up to 79 cases per 100,000. The mortality is still high at 8.7%, 30-day mortality. The recurrence is also high, up to 31%. And let me tell you here that if a patient has H. pylori and you do not treat H. pylori, the risk of recurrence of the peptic ulcer is 90% within 1 year. And the recurrence of bleeding is up to 31%. So the cost is estimated to be high. So really it's a financial burden also from an upper GI bleeding standpoint. We can see here that through time, upper GI bleeding has been decreasing, whereas the lower GI bleeding has been increasing. And I think we relate this to patients popping PPIs and with the ability of PPIs of treating these ulcers without even prior to their diagnosis. What is the etiology of upper GI bleed? We can see here about 50% comes from whether it's a gastric ulcer or a duodenal ulcer. Gastric erosion is about 25%. It's really about 75% of the bulk of this. Esophagitis, Mallory-Weiss-Taylor, about 10% both. And varices, luckily, is only about 10%. Then we have those rare causes, 10%, whether be it a neoplasm, AVM, esophageal ulcer, a stomal ulcer, or doulofoy, which we dread as endoscopists, and hemophilia, as well as aortoenteric fistulas. So what do we do with these patients initially? Resuscitation is really essential. So prompt assessment and empirical resuscitation using the airway, breathing, circulation, disability, looking at the patient's mental status, as well as exposure, looking at the patient, whether they have ascites, they have criteria for liver disease, stuff like that, and then triaging them accordingly. And doing the shock index, which can be used as really as an indicator of severity and should be calculated as a heart rate divided by systolic pressure. More than 0.9 is really a reliable indicator of hemorrhagic shock. Security IV access, too large bowel, and then urgent blood testing, the things that we do on a daily basis with the CBC and coagulation profile, as well as liver functions and kidney function with a cross match to be ready for transfusion if needed. So from a resuscitation standpoint, we need to find out if the patient is in shock, call the gastroenterologist, not call the gastroenterologist, call the ICU guy if the patient is in shock, and even wind up with the hemorrhagic protocol for each hospital that you work at, and look at detailed history for the patient, whether they've been taking anti-thrombotic medications, whether they've been using non-steroidals, or they have any other comorbid conditions. And don't forget the surgeons in cases like this. So call your surgeon from the beginning to be aware of the patient, even if they're not going to surgery immediately. What are the bad predictors of adverse outcome in these patients? Whether the diagnosis of peptic ulcer disease, varices, is worse from an outcome standpoint, and cancer. Age above 60, comorbid conditions like liver disease or cardiac disease, hypertension, shock as initial presentation, coagulopathy, the onset of bleeding in the hospital, transfusion requirement of more than 6 units of packed RBCs and red blood in the stomach, as well as rebleeding from the same lesion, and the need for emergent surgery. Do we need the NG tube. In the old days, we used to put the NG tube in order to lavage the stomach. Really, the ACG came up with recommendations in 2021 saying that really we don't need the NG tube. It used to be thought that we put the NG tube to see if there's blood in it, but the negative predictive value is 78%, and or clean the stomach. It really doesn't work. So you want to put the NG tube, it's fine. If you don't want to put it, it's okay too. From a resuscitation standpoint, once you look at the patient, you want to find out whether the patient has a variceal bleed or a non-variceal upper GI bleed, because this is really completely different from a therapeutic standpoint, whether it's medication or endoscopic-wise. And we want to look at the severity assessment, risk assessment for these patients, and we usually look either a Rock-Hall or a Blatchford score, and these are validated from a prognostic standpoint for these patients. So low-risk patients with a Blatchford score of 0 to 1 may be considered for discharge without even admission to the hospital, and high-risk patients should be prioritized for endoscopy and escalation of care. So what is the Rock-Hall score? It looks at vital signs plus age and comorbidities and predicts the risk of further bleeding and mortality in patients with upper GI bleed. The Glasgow-Blatchford score also look at the clinical information with the vitals, melena, syncope, liver and heart disease, as well as laboratory information with the hemoglobin and the renal function. And really it predicts also intervention, whether the need for transfusion as well as endoscopy and surgery in patients with upper GI bleed. And again, a Blatchford score of 0 or 1, the patients probably do not need anything inpatient. It can be dealt with as an outpatient. Just to give you an idea, the Glasgow-Blatchford score looks at the hemoglobin, looks at the urea, the systolic blood pressure, looks at the pulse, melena, syncope, as well as hepatic disease and cardiac failure. And again, a GBS score of 0, the patient can be dealt as an outpatient, and even 1, they don't need to be admitted, and they can be dealt as an outpatient from that aspect. What about the Rock-Hall score? The scoring system really looks at the age, whether below 60, between 60 and 80, and above 80, with the presence of shock, comorbid conditions like cardiac failure, liver failure, renal failure, and the diagnosis is very important. If you have a Mallory-Weiss diagnosis, you are much better off from an outcome standpoint than you have a malignancy or a peptic ulcer disease. And looking at the major stigmata of recent hemorrhage, the things that we see on endoscopy, which I'll discuss later. The maximum score is 11, and a score of 2 or less has low risk of rebleeding and very low risk of death, and a score of more than 8 or more has a high risk of rebleeding from that standpoint. What about transfusion? We moved into a restrictive transfusion behavior because of this study, really, that showed us that a restrictive transfusion approach with transfusion of a hemoglobin of 7 and above and keeping the hemoglobin between 7 and 9 has a much better percentage regarding mortality, a restrictive at 5% and a liberal at 9%, and much better also regarding rebleeding, 10% versus 16%. Knowing that patients with cardiac problems, they may need that oxygen carrying capacity, so we want to start transfusing them at a hemoglobin of 8. What about IV PPI prior to endoscopy? So really, most of the guidelines, whether be it the American College of Gastroenterology or NICE, the British, they do not recommend doing PPI prior to endoscopy. But let's face it, do we do it? Yes, we do it. Because after we do the endoscopy, sometimes it's delayed giving the patients the IV PPI, and it's very important for the IV PPI to be on board when we do our endoscopic therapy because it does affect the lysis of the clot, which I will discuss also later. What about endoscopy? When do we do the endoscopy, really? The endoscopy is very important to be done depending on the patient's clinical status. We need to stabilize the patient and rush for the endoscopy within the first 24 hours. In practicality, we should do it within the first 6 to 12 hours because the earlier we can control the bleed and know what the patient has with the risk stratification and looking at the source of bleeding, the better usually the outcome is. So if you have a patient with a shock, for example, or ongoing bleeding, then we need to talk to the endoscopist to stabilize the patient and do the endoscopy fast. Whether you have a Rock-Hall score of more than 2 or a GBS score of more than 12, or the patient's throwing up blood, bright red blood, these need to be acted upon fast from that aspect. And if they have a contraindication, for example, for interruption of the anticoagulation if they're taking it, then it's very important to jump on these patients and do the endoscopy in order to treat it and stabilize them and stop the bleeding accordingly. All other patients with acute upper GI bleed should otherwise receive early endoscopy, again, within 24 hours and ideally within 6 to 12 hours. And if the endoscopy failed to achieve hemostasis, then we need to consider interventional radiology to do a CT angiography and embolization, and again, involve the surgical team early, just in case all things fail. And the patients with bright red blood per rectum with shock index of more than 1 should also be referred for urgent EGD. And if the EGD is normal, we need to do really a sigmoidoscopy and possibly CT angiogram in order to identify the source of the bleeding. An early colonoscopy should be encouraged if colonic bleed is suspected. So we go for endoscopy, and we go in and we see an ulcer with the actively bleeding vessel. We call it, as a classification, a Forest classification, a Forest 1. If they have an active spurting, if there's oozing from a vessel, it's either Forest 1A or 1B. If you have a patient with a visible vessel, which is Forest 2, or an adherent clot, or a pigmented base, this is Forest 2, A, B, and C. And if you have a clean base, which is the best from a prognostic standpoint, it's Forest 3. Why are these important? Because really the risk of rebleeding depends on the finding on endoscopy. For Forest 1A, the risk of rebleeding is up to 55%, depending on the study you looked at, but at least half of these patients rebleed, even if you're able to stabilize them. Excuse me. So the stigmata of bleeding on endoscopy really assesses the risk of rebleeding by the Forest grade, as I said. And the prevalence, luckily, that the patients with Forest 1 is only about 12%, whether it's spurting or an oozing vessel. And a non-bleeding visible vessel is about 8%. And the majority of patients, 55%, has a clean base and a 60% with a flat pigmented spot. And again, that's really important from a mortality standpoint, because the mortality is the highest when you have a vessel that's spurting blood at the time of endoscopy, up to 11%, whereas with a clean ulcer base, the mortality rate is about 2%. So really knowing your enemy is very important in order to predict the outcome for these patients. So when we scope these patients, what do we do? Well, initially, we injected them with epi. This was 30 years ago. We realized that epi really alone does not do anything. So epi has to be combined with either a heater probe. We want to obliterate that vessel so it doesn't bleed, block it completely, or use a clip. It's a little metal clip that we close the vessel with. Other new endoscopic armamentarium for us that we can stop the bleeding. If we can't even apply the vessel or the heater probe, what do? We can use a hemospray, which really initially was used at the military for people who bled in the field, where you spray them and it kind of has clotting factors where it stops the bleeding and it works wonders. But unfortunately, it's very short-lived. It acts only for 24 to 48 hours. So an underlying essential therapy is much better than the hemospray, but this will be the last resort in order to stop the bleeding and stabilize the patient and revisit the issue again. And recently, we have this, what we call a VESCO, the over-the-scope clip, where we can go in and clip that vessel in order to stop it. And this is really like a bear claw, very aggressive, but very effective. So what if we fail endoscopically from the first time? All the guidelines tell you that we should repeat the scope another time in order to try to stop the bleeding. Why? Because it really has less complications than either interventional radiology or surgery from that aspect. And again, it's associated with the increased mortality and law of diminishing returns. Still, you have to go for another look and try to stop the bleeding. If we cannot stop the bleeding with a second look, then we move to either interventional radiology or surgery. And patients with variceal bleeding, if we can't stop the bleeding, also we can go either to Sungus-Taken Blakemore tube. Now we're using even the self-expandable metal stent in order to put the pressure on these varices and then pull it out within 24 to 48 hours later to treat the underlying etiology. And then we can do TIPS, and that's really what we do. If we can't control the bleeding with variceal bleed, then TIPS will be the second step immediately. And we can do the balloon-occluded retrograde transvenous obliteration if needed, especially when patients have gastric varices. So to sum it up, really, if you have a patient with upper GI bleeding with a very low clinical risk, with a Glasgow-Blatchford score of 0 to 1, then you can discharge them home and treat with it as an outpatient. If they have a score that's 2 or above, then you can put them in the hospital, you do the resuscitation, you attend to the active comorbidities, and you do the transfusion if needed. We can do erythromycin in order to empty the stomach, 250 milligram dose, just 6 hours prior to endoscopy. which helps us see better as endoscopists. And there's no recommendations for or against PPIs, as I mentioned, but we all do it just before endoscopy. And then proceed with the upper endoscopy within the first 24 hours. If you have low-risk endoscopic findings, like a clean-based ulcer or non-bleeding malar or Weisstein erosions, then the patient can be discharged after the endoscopy. If you have a higher risk stratification with a forest, as I said, 1 or 2, then the patient needs to be admitted and treated accordingly. So what about the rationale for acid suppression upper GI bleeding post-endoscopy? Really, acid, what it does, it decreases platelets aggregation and favors disaggregation, and increases clot lysis due to pepsin activity, as well as increased fibrinolytic activity. Therefore, the target of the pH that we want to achieve is 6 to 6.5 in order to preserve the clotting effect and preserve the stopping and the hemostasis of the bleed. And studies have shown that if we do the usual dose of the PPI, 80 milligram IV, with a continuous 8 milligram an hour infusion in comparison to placebo, the rebleeding is much better with the PPI use in comparison to placebo within 3 days, 7 days, as well as 30 days, and decreases numerically the number of surgeries and death, but not statistically significant from that aspect. Again, here looking at the meta-analyses of IP PPIs used in patients with peptic ulcer disease bleed, the rebleeding rate is better when we use the PPI, and the number needed to treat is about 13. Again, surgical intervention is better numerically, as well as repeat endoscopy after normalization is better from that aspect. So what about other management regarding the patients with non-variceal upper GI bleed? Patients with bleeding peptic ulcers be started on PPI, as I mentioned. Check for H. pylori, granted that when the patient is bleeding, H. pylori may be falsely negative, so it has to be checked later. If there's high suspicion of PPI, it should be treated. And remember, the WHO in 2018 came about and said that the UAE is one of the areas in the world that has clarithromycin resistance. So triple therapy should never be used alone because of the high resistance rate, and the eradication rate drops down to about 35 to 40% only. So triple therapy with clarithromycin, amoxicillin, and PPI should not be used. It should be either a quadruple-based therapy with the clarithromycin or quadruple-based therapy with bismuth. And the most recent guidelines from the ACG, I was shocked actually to see it, which was just written a few weeks ago, saying that the first line of therapy should be a bismuth-based quadruple therapy, and the suggested second line would be high-dose amoxicillin therapy with high-dose PPI, only dual therapy, or rifabutin therapy, which we have available here over the last couple of months, came available to us in the UAE. So again, recommended, depending on the forest classification that we saw, high-dose PPI for 3 days, IV continuous, followed by, depending on the stigmata of recent hemorrhage, continue with BID PPI for 2 weeks, then go back to the regular dose of once a day. And again, dealing with recurrent bleeding, repeat endoscopy, then either interventional radiology or surgery. And failure of endoscopic therapy suggests interventional radiology for endoscopic failures, as I mentioned. Mortality rate really relates also to the comorbid conditions as well as age, as I mentioned previously. The presence of shock or continual bleeding which increase the rate 50-fold of increased mortality from that aspect. If we go on to variceal assessment, if we think that the patient has upper GI bleed from varices, the decision should be made really whether the patient has either non-variceal or variceal, looking at the patient whether they have a history of cirrhosis or varices, and the stigmata of recent of liver disease, as well as blood results of radiological findings. And then we have to go through the things that we usually go through on a daily basis: fluid resuscitation, giving them octreotide, either octreotide or samidostan or terlipressin. All of them are the same from vasoconstriction standpoint. Prophylactic antibiotics to prevent the infection, whether it's SBP or pneumonia. Looking at the prothrombin time, trying to correct it, as well as infusion of platelets if the platelet is less than 50, and transfusion of blood if the hemoglobin is less than 7. So Looking at coagulopathy, if the patient need urgent discussion with the gastroenterologist in order to jump on this. Usually it should be done within the first 6 hours, 6 to 12 hours max, because these are very sick patients that they actively bleed, they can go south fast. And looking at the patients, whether they're taking NOACs, which may benefit with discussion with the hematologist, what you want to do with it, and reversal of coagulopathy, you want to give fresh frozen plasma or platelet transfusion, as I mentioned. So if you have a suspected variceal hemorrhage, you can use either octreotide and the standard terlipressin, empirical antibiotics, and erythromycin, as I mentioned, to clear the stomach.
Dr. Ahmed, you have 1 minute.
What can we do from a variceal standpoint bleeding? We can do endoscopic band ligation therapy for esophageal bleed. Okay. So we can do endoscopic band ligation for esophageal bleed, or we can do band ligation for extension into the cardia, or what we do is histoacryl injection for patients with esophageal varices, and if it all fails, TIPS will be the way to go. And this is really what we do from an endoscopic standpoint. What about antithrombotic therapy? Really, we want to do a resumption of antiplatelet therapy as soon as hemostasis is achieved, and there's no increased risk of post-procedural bleeding when you're taking aspirin, so continue with the aspirin. And there's, in fact, a high mortality rate when we stop the aspirin, especially for the patients in need. Looking here at the management of antithrombotic agents, vitamin K antagonists, the ACG recommends against the use of fresh frozen plasma in these patients, and we suggest the use of prothrombin complex concentrate. If you're using a direct thrombin inhibitor like dabigatran, they suggest against the administration of idarusizumab, which is the antagonist for this, unless you have a high threatening situation for these patients. And there is also, if you're using other medications like evaroximab, it's also recommended against the use of these antagonists because of the high risk of clotting from that aspect. I'm sorry, I guess we're blocked from that aspect. We'll do this for other time regarding a lower GI bleed. Thank you for your attention.